right? And so the real question in my mind isn't going to be whether combinations work, but who should get the combination, and what the combination should be, because the person who's not destined to respond to single agent, PD-1, blockade, what was different about their cancer, and how do you then develop a rational combination that would increase their likelihood of benefiting? And the anecdotal at this point, not anecdotal, but the early clinical trials data from the IPI plus Nivo combinations in melanoma suggests that there is a value to doing some combinations, because you enhance the proportion of individuals who seem to be benefiting from therapy.
That's exactly what's happening now. So I think from this ASCO, the data being presented in the next year, we think so much about these agents in the lung cancer community. We'll see frontline trials, dedicated frontline trials versus chemotherapy. For most of those trials, the biomarker PD-L1 is being used, again imperfect, but at least trying to enhance response rates, since chemotherapy itself has a reasonable response rate. But for those patients that don't make that cut, the other 60, 70%, exactly, that's the group we should think about what combinations work, and actually understand a little bit about the immune microenvironment and know, why are these patients not responding? Is it the lack of T cells? Is it another immune suppressor of some sort? These are all things that I think they're already going, but will be enhanced in the next year.
So I'm going to ask Mark a provocative question, so that you can give Dr. Herbst advice on his master lung protocol, okay?
I'm involved in that, actually.
Yeah, well, so you can actually influence it.
Okay.
One could argue, that given the certain knowledge that almost everybody with metastatic non-small cell lung cancer treated with a non-immunotherapy will have, by any conventional definition, a transient response, be that transient response a minute or a year, that it's still a relatively transient response. One could argue that everybody with newly diagnosed metastatic non-small cell lung cancer in a clinical trial setting at this point should be offered treatment, if they're otherwise eligible, with a checkpoint inhibitor antibody to sort of tease out that 20% who are destined to do well, and then take the other 80% who didn't do well on the checkpoint, and then consider, based upon molecular phenotyping, what the next best therapy would be. Would you think that's a good study design?
Absolutely, and I think that's where the field is going. The master protocol really is going to, I think, be very helpful, because at least half the patients are not going to find the initial 4 markers that are being looked at, and so we're going to have extensive molecular information on these patients, and we'll learn something about the treatment with the immunotherapeutic arm of that particular trial. As Roy mentioned, I'm happy to say that I think there are 4 or 5 patients randomized already on the nivolumab first-line trial, which again is using PD-L1 status as a biomarker, but a relatively low bar. So I think about 80% of the patients are going to qualify for that trial, and it's being compared to investigators' choice of standard platinum-based doublets. I think that is exactly where the field needs to go, and we anticipate that, and are hopeful that the activity of the single agent nivolumab will be at least, if not greater, than what we've historically and will see in this trial for platinum-based doublet. Platinum-based doublet, although it's our standard of care, is tough treatment.
Yeah.
The responses typically are not very durable. And I think this has a real chance in a proportion of patients, and we can argue in the first-line treatment. I'd be interested in Roy's idea, perhaps in previously untreated patients, that the population benefiting may be higher, although we don't know that yet, because there are very few patients, previously untreated patients to date. We'll see a couple of abstracts at this meeting that look at previously untreated patients, but I think we're all hopeful, getting to your point, that if you can treat patients with a monotherapy that's very well tolerated in the majority of patients, that has the durability that we've not been accustomed to in lung cancer, that will certainly move the bar in our disease.
Yeah, I